Hello, my name is Jason Vanstone. I'm a research scientist with the Stewardship and Clinical Appropriateness Department, and I work with the Antimicrobial Stewardship Program. I'll talk to you today about what that program is and why it's important for nurses to play a role in antimicrobial stewardship. So, the main idea here is that we have a problem, and this is a problem really on a global scale. And it's important enough that back in 2016, the United Nations, for the fourth time in their history, had a high-level summit on a health issue. And this issue was the problem of antibiotic resistance. So what is antibiotic resistance? Let's talk about that for a minute. Well, when you have regular run-of-the-mill bacteria like you see here, and we throw antibiotics at those guys, they die. That's great. That's what the antibiotics are intended for. The problem of antibiotic resistance, and that's what these guys look like. If you look inside of them, they've got their bacterial chromosome and these extra little chromosomes that are called plasmids. But they get killed when you use antibiotics. The antibiotic resistant bacteria, these occur when the regular bacteria get mutations that prevent the antibiotics from doing what they're supposed to do. So they confer antibiotic resistance on these bacteria. And this is what creates a huge problem for human medicine. So it makes these bacteria very difficult to treat. We cannot use often our first line antibiotics on them. And so it makes it harder for patients to recover because we can't use the best antibiotics for them. And it leads to all sorts of issues in medicine. And so what drives this antibiotic resistance? Well, really what it comes down to is our use of antibiotics. So you can see here, this is a graph from some data that was collected in the United States. And along the bottom, it shows the months of the year, January through December. And the blue portion of the graph is showing penicillin prescriptions. And so you can see that in January, February, March, sort of the winter months, we see high levels of antibiotic prescriptions. Makes sense for us. It's cold and flu season. Lots of people are going to the doctor and getting prescriptions for antibiotics, sometimes unnecessarily. But when we get into sort of May, June, July, it gets to the summer, cold and flu season has ended for us. People go outside and spread out, and so there's less disease transmission, and we see fewer antibiotic prescriptions. But then as school starts up again in the fall and it gets colder, people head indoors, and we start to see the cold and flu season starting again, and we see more antibiotic prescriptions. And so what's interesting about this graph is that if you compare that blue valley and the peaks to the orange line, which is the resistance to the penicillin or ampicillin in E. coli bacteria. And you can see there's about a 1 month lag between the blue peak and the orange peaks, but they correlate with each other. So when we see high use of antibiotics, we also see high levels of resistance in those E. coli bacteria. And as we see less use as we get into the summer, we see a corresponding decrease in the amount of antibiotic resistance. So we know from the data that the more antibiotics we use, the more antibiotic resistant bacteria we're going to see. And we know that we use a lot of antibiotics in Saskatchewan. So these data here come from the Canadian Antimicrobial Resistance Surveillance System, or CARS, their 2021 report. This is a group under the Public Health Agency of Canada. And so what they do is year after year, they look at antimicrobial use across Canada, and they can use that data to sort of compare how different provinces and territories are doing in terms of antimicrobial usage. So we're looking at defined daily doses on the left-hand axis there. And so that's just kind of a measure of how much antibiotics are being used. So you can see across the bottom, there's BC and the territories are combined, and then kind of going west to east across the country, Alberta, Saskatchewan with our flag there, Manitoba, Ontario, and so on. And the different colored bars just represent the different years that are represented there. So you can see for Saskatchewan, the kind of beige bar there is 2015, and then 2016, 2017, 18, and 2019 in the purpley blue there. The point here is that you can see year over year, we are, at least compared to our immediate neighbors, the highest users of antibiotics compared to BC, Alberta, Manitoba, Ontario. And in fact, across the country, they used to combine New Brunswick, Nova Scotia, Prince Edward Island, and Newfoundland, the Maritimes, into one category here. So over time, we've been the second highest user of antibiotics across Canada. And even still today, with the data separated like this, we are among the highest users of antibiotics in Canada. And so that indicates that we've got a lot of room to improve the appropriateness of our antibiotic use and how much we're using here in Saskatchewan. So that's where antimicrobial stewardship comes in. The goal of antimicrobial stewardship is to ensure that we're using antibiotics appropriately and only when necessary. And so there are a few key components of that. So that very first piece is asking the question before an antibiotic is used or a patient is treated, is the antibiotic necessary? And if it is, well, that's great. That's why we have antibiotics. But we want to ensure that we're using the right drug, the right dose of that antibiotic, the right duration, and the right route to ensure that the patient's getting it in the best way. So let's dig into that a little bit. The very first question of, is an antibiotic necessary? And this is where we can actually stop a lot of our antibiotic use that is not needed. And really this comes down to treating bacteria versus attempting to treat viruses. So these are different, biologically speaking. Bacteria are different things than viruses are. And the main piece that I want to talk about here is that antibiotics and the way that they work are targeted to treating bacterial infections and not viruses. So when patients have a viral infection, and we see this a lot, especially in community, where people are being treated for viral upper respiratory tract infections like colds or flus, or even COVID. A lot of people get treated with antibiotics, and we know that it actually has no effect on the virus or the infection from the virus. Antibiotics are only effective in treating bacteria. And so, as I said, this is something where we know from data that there's a lot of room to improve here. So data from the US, there's similar data in Canada, but they looked at outpatient prescriptions in the US. This was back in 2012, I believe. And they saw that at least 30% of the outpatient prescriptions were unnecessary, meaning the antibiotic was not required at all. These were being prescribed for indications like upper respiratory tract infections, so viral infections, things like treating people's asthma and stuff like that. So indications for which there is no requirement for using antibiotics. We know it's not going to benefit that patient. And so that was their low end estimate. So that was at least 30%. They thought that even up to half of the antibiotics, up to 50%, might have been unnecessary in their study. So this shows that even just cutting out the unnecessary antibiotic use, there's a huge amount of room for improvement in terms of reducing unnecessary antibiotic use. The other portion of that is that 70 or so percent of prescriptions that were necessary, they still found a need to improve the type of drug being selected, the dose, and the duration of those treatments. So let's talk more about those pieces. Is it the right drug? And there are a few different things to consider here, including whether the right drug is being used to treat the right bug, the right bacteria. But another big one that we often see is using the right spectrum of drugs. So there are two different types of antibiotics, broadly speaking, narrow spectrum antibiotics and broad spectrum antibiotics. And the difference here is that narrow spectrum antibiotics tend to treat fewer or affect fewer bacteria compared to broad spectrum. So broad spectrum antibiotic could kill many different types of bacteria, whereas narrow spectrum tend to focus their activity and kill only one or a few different types of bacteria. And so this is important when we think about things like our microbiome. So this is a very important piece of being a human. We have all of these bacteria that live in us and on us, and they do all kinds of beneficial things for us, helping with digestion and various other protective factors for us. And so if you take antibiotics that are more broad spectrum than they need to be, you can actually be affecting not only the bacteria that are infecting someone that you're actually trying to kill, but a lot of these other good bacteria that are beneficial for us, the probiotics, if you will. And so that's something we want to avoid because that can lead to other health issues. So it's kind of akin to Morpheus in the Matrix offering the red or the blue pill. Which one would you want to take to ensure the best health outcomes? And so some of these outcomes could include things like I've pictured C. difficile here. This is Clostridioides difficile now. And so this is a bacteria that can cause really, really severe diarrhea. And so this is something that's sometimes an effect of being on broad spectrum antibiotics because it wipes out all the good bacteria in our guts that prevent these bacteria from becoming prominent and really causing issues for people. All right, so is it the right dose? This is another question to consider. And this is where we'll talk a little bit about Goldilocks or the Goldilocks zone. Getting something just right. You know, it's not too hot, it's not too cold, it's just right. So the same principle applies to antibiotics. So we want to make sure that we're not obviously providing too high of a dose because that can be bad for the people that we're trying to treat. If you provide too low of a dose, then you might not actually be killing the bacteria and preventing the infection or curing the infection that you're trying to treat. So getting that right dose is key in ensuring that we're treating the infection but not harming the patient. Another thing to consider here too with some antibiotics is that regardless of the dose, they can be harmful to people, right? So we know one antibiotic called vancomycin, which can actually be quite nephrotoxic, so it can actually harm patients' kidneys. And so when we're treating patients with this antibiotic, they're monitored quite closely, especially in hospital, to ensure that the level of vancomycin isn't building up in their bodies to try to prevent as much damage to the patient's kidneys as possible while we're trying to treat the infection. Duration of treatment is another one where we have a Goldilocks zone. So if you consider, for example, a urinary tract infection. So this, I'm going to put a little graph on here just as an example, but we'll see an increasing number of bacteria along the left axis there. And so your days of antibiotic treatment are on the bottom. So as you go from left to right, you're seeing an increasing number of days. And then the bacteria you can see dropping. So if we have a patient with a bacterial infection, we can see that as we start to treat with antibiotics, we start to see a drastic decrease in the number of bacteria that are present in that patient. If we continue to treat for 7 days or 10 days, eventually we get to a point where we're not just treating the bad bacteria, but we're actually starting to promote the growth of antibiotic-resistant bacteria. So any bacteria that are in that person that are resistant to that antibiotic, by exposing them to this antibiotic for a longer period of time, we're essentially selecting for those bacteria. So we're eliminating their competition and we're allowing them to grow in place because they're resistant to the antibiotic that is being given. And now they don't have the competition of other bacteria around to prevent them from being able to get all the nutrients they need. And so we see a point where we might actually be promoting antibiotic resistance in people by using long duration treatments. So again, it's about finding that Goldilocks zone where you've provided enough antibiotics to help the body eliminate those bacteria, the bad ones that are infecting. But we're also trying not to promote the growth and development of antibiotic-resistant bacteria. So another piece to talk about is the right route. And so in hospital, where we do a lot of our antimicrobial stewardship efforts, we see a lot of IV antibiotics. And often this is because patients are quite sick, and it's just a great way to really get high doses of antibiotics into them right off the bat. One issue here potentially is that they're expensive, more expensive usually than oral antibiotics. And of course, this takes a lot of nursing time as well, to be changing out antibiotic bags and things like that, or IV bags and things like that. And so one thing to consider is using oral antibiotics when that's an option. It's cheaper, it's time saving for the nursing staff, but from a patient perspective, it's also has benefits in that it's reducing one additional opportunity for creating new infections. So when you've got an IV in the arm, if it's only there to be providing antibiotics, that's another potential port of entry for infections. So if we can get rid of that and just provide the antibiotics orally, we're reducing more options for patient harm. So I just want to talk quickly about then what the nurse's role is in antimicrobial stewardship, or could be. And this is not just me talking. So there are papers, and this is even from over 10 years ago now. This is 2011 that this was published. People actually study this, and they want to know what is the role that nurses can play in antimicrobial stewardship. And so this is a table that I pulled from this paper that's listed on the left here. And it just talks about, on the left side of it, there are different aspects of management for patients. So looking at treatment specificity, what is the associated risk there? So as I talked about, using a broad spectrum antibiotic is a major contributing factor to C. difficile infection and antimicrobial resistance. So we want to avoid broad spectrum antibiotics when possible and use those more narrow spectrum antibiotics. And so their point here is, how can nurses contribute to that? And so they talk about additional support and training of nurses could ensure that treatment is in line with the microbiology results, and that the use of broad spectrum antimicrobials is limited where possible. So you can see there's lots of other examples: the duration of treatment, how nurses can contribute there, the route of antibiotic administration, and so on and so forth. And then there's another paper here from 2016 that talked about the critical role of the staff nurse in antimicrobial stewardship. And especially talking about how it's unrecognized, but actually already there. Nurses actually do a lot of this stuff, maybe without even recognizing that this is part of what we would consider antimicrobial stewardship. And so this is a paper, or a table from that paper. And so what it's showing is kind of the patient's journey from admission on the left there all the way down to their progress, education, and discharge at the bottom. And so then across the top, they're showing the different specialties. So the nursing, the microbiology, pharmacy, infectious diseases, so on and so forth. And you can see that for most of the different specialties, they're kind of spotted here and there in terms of wherever there's a dot, that's something that they have a role or a connection to in terms of that patient's care. But for nurses, every single one of those pieces had a dot beside it. So right from patient admission, doing the triage and the appropriate isolation, getting an accurate allergy history, right down through the clinical progress and discharge. So educating the patient, the changing from IV to oral antibiotics, the outpatient management, things like that. Nurses play a role in every one of these points where antibiotics can be ensuring that we're using antibiotics appropriately. And locally here, so a few years ago, we had an intern that was doing her MPH. Her name was Lorraine, and she actually did a kind of quick little survey or interviews with some local nurses, just to try and understand what are some of the common barriers that we're seeing here to nurses for nurses in terms of practicing antimicrobial stewardship. So one thing that she understood from her work was that a lot of nurses were saying they're just not familiar with the concept of antimicrobial stewardship. So hopefully this presentation will help to clear some of that up and make people aware of what exactly this topic is. Another common barrier was that the nurses thought that antimicrobial stewardship was really not in their scope or function because they're not the prescribers. And while there's some truth to that, obviously there's only so much control you can have if you're not prescribing. The reality is that there's a lot of influence that nurses can have in terms of prescriptions. And so these are the people, nurses generally are the people who are in closest contact with the patient. They understand the signs and symptoms that the patient has. And so they're really the people most well situated to understand what the symptoms are and how that relates to whether or not antibiotics are needed. And they can play a huge role in influencing prescribers' decisions to prescribe antibiotics. Nurses not being confident about their knowledge of microbiology and antibiotic use was another thing that came up. And so this is something that's a little bigger in scope, obviously, than we're able to cover here. But just knowing that there are resources out there for you to gain more knowledge about this, whether that's through formal education or just through sort of on-the-job learnings. There are plenty of people who are willing to work with different nursing groups and nursing units or individuals to help increase this knowledge. And our antimicrobial stewardship program is one of those groups. And then the last one that she found was a lack of awareness about the negative effects of inappropriate use of antimicrobials. So this idea that antibiotics cure, right? We think that these are beneficial drugs that we use and they help people feel better. And while that's true when you're treating, a bacterial infection, we also have to understand that antibiotics are just like any other drug in that they have side effects. And so those can be something that can be very actually severe. I was talking about vancomycin earlier, which can actually damage a patient's kidneys. And so we don't want to have to go the route of, okay, we cured your infection, but we've damaged your kidneys and now you're, in trouble there, potentially for the rest of your life. So we have to understand that there are downsides to antibiotic use. And these are not just benign drugs that you can just add on just in case, because they actually have severe outcomes potentially associated with them. And that includes, as I talked about at the beginning, this global issue of increasing antibiotic resistance. Every antibiotic treatment that is given is another drop in that bucket of driving that antibiotic resistance and increasing the number of antibiotic resistant bacteria that we see. And that puts all patients around the world at higher risk for having these antibiotic resistant infections and making it harder for us to treat those. So that's it. I would invite you can either scan that QR code to check out our website. We've got lots of great information and tools on there, education tips, or you can hit the incredibly long website address up there. If you have more questions, feel free to reach out to us at our email down below, antimicrobial.stewardship@saskhealthauthority.ca. I would like to thank you very much for your time.